are.
Yeah, go ahead.
Yeah.
Good afternoon. Thank you all for coming out this afternoon to our 7th and final listening session for our PDSN commissioners to hear the thoughts and ideas of our stakeholders on the 10% FMAP that was included in the American Rescue Plan. As I said, this is the seventh listening session. It's Commissioner Rollinson, who is the chair of our commission. It's her second listening session. She did one in Charleston earlier this week, and I believe Commissioner Miller, this is the third one. Okay, so we're happy to have two commissioners here, Commissioner Rollinson and Commissioner Ed Miller, and we're happy to hear from all the stakeholders on their thoughts on the FMAP, and I'll let you know that as far as some ground rules, in order to be heard, you're going to have to come up to the podium and speak. The camera and microphone is set up so that we can do it there, and as well as anybody who's online, if you have comments for the chat, put them in the chat box, and we will address them as we go along. And now that that's taken care of, I will turn it over to our host commissioner, Commissioner Rollinson.
Well, good afternoon. I am Commissioner Stephanie Rollinson. I like for you to call me Stephanie. I represent the 7th Congressional District of South Carolina. However, this is a statewide appointment, so I look out for the entire state. But my counties include Horry, Georgetown, Marion, Marlboro, Dillon, part of Florence, and Dillon and Chesterfield counties. I grew up here in Florence. My husband Kevin and I have two beautiful daughters, Mary Catherine and Ella. My passion for my educational background is in real estate, politics, and healthcare administration. So I cover a lot of different areas in my areas of expertise. I was a member before being appointed to this commission, I was a member of the Florence County Board of Disabilities and Special Needs and a member of their foundation board. My passion for I call them differently abled, for the differently abled of South Carolina began early. My mother was deaf, so I grew up with a mother who was profoundly deaf. And then about, I guess it's been 4 years ago next week, my daughter and my family was involved in a catastrophic automobile accident. And my daughter became a quadriplegic at that point. And so she is a spinal cord patient, and but she does very well. I'm very excited. She's done a great deal of work on herself, and will be going off to Clemson in the fall. So I'm very proud of her. I'd like to take a moment to introduce and welcome my fellow Commissioner, Eddie Miller. Commissioner Miller and I began on the state board at the same time, which was about a year ago. I have just thoroughly enjoyed my time with Commissioner Miller. He and I play off of each other really well. So I'm going to let you just introduce yourself to these folks. He does represent part of Florence County, which is the Lake City area of Florence County.
Good afternoon, everyone. Everyone's doing fine? So am I. It's nice in here.
Yes.
Anyhow, I always love to talk about money, especially when you have some. Because if you don't have any, then folks say, why are they here? Anyhow, I represent the Majority Whip Congressman James E. Clyburn's district. It's 16 counties in his district. I grew up in a very large town called Kingstree, South Carolina. Any of y'all ever heard of Kingstree?
Yeah.
Y'all go through there quite often?
I do.
McDonald's. McDonald's.
I hit the McDonald's.
My cousin, I have one set of my family, they go to McDonald's. That's where they have breakfast. And I have one lone cousin, he goes to Hardee's. That's where he is. It's a pleasure being here, and we are here with an open ear and an open mind. Okay? That's what we are here for, because you are the ones that have your feet on the ground to tell us where it's most appropriate for us to spend some money. Doesn't that sound good? I'll give back the balance of my time.
Well, I do want to recognize our staff that is here as well. We have our CFO, Pat Malley, Rob McMurdy, and Mike Mickey. Mike is with our IT, and Rob is our acting legislative liaison. So we are glad to have them with you. We also want to thank all of you for being here, and those that are joining us online. We certainly appreciate it, and we hope that you will give us comments and feedback. We just want to, this past year has been difficult, to say the least. In some cases, it's been catastrophic and tragic for our nation, our state, and those that we serve at DDSN. Today, we celebrate those heroes, those who have made it through this and come out to the other side. And they're workers and families, and they have ensured that we're able to continue doing the services and the things that we as commissioners want to see happen with our consumers. However, this group of people deserve to be heard. And that's exactly why I recommended that we host these events several months ago in our commission meeting. We want to hear from you. We want our stakeholders, and we want some concrete ideas for your needs and ways that we can help our service delivery groups recover this year. It is a new day at DDSN. We're a different commission than has existed in the past. We are under new leadership, and it is our goal to build an even better service delivery system for those who are differently abled in South Carolina. Many have asked how DDSN will allocate the extra resources directed to our agency by the American Rescue Plan. That's precisely why we're here today. To make it simple, the additional 10% FMAP money, or the federal medical assistance percentage, that will be in place for DDSN from April of 2021 to March of 2022 is extra federal money that is coming into the state based on our state's usage of the home and community-based services from Medicaid. These extra funds will be available for 1 year only. However, we will have 3 years to spend that money. We cannot take that money. The money is to be used to add to, not replace, existing state funding of Medicaid. We can't go, we can't go below or cut services, but we can use this money to expand them. Funds can be used to design and implement short-term activities to strengthen the home and community-based service system in response to COVID-19 public health emergency, as well as longer-term strategies to enhance and expand HCBS and to sustain promising and effective programs and services. We got 3 years, as I told you, to spend this money. Those are the perimeters. We have to submit to DDSN's plan to our good friends over at the Health and Human Services Department by the end of this month. We are cutting it close, obviously, and so the information we gather today is going straight into a system, and we'll be meeting and making a firm list later on this week. If you want more detailed analysis of the extra money, our staff has given you some brochures about it. They're very extensive. Take your time, read through them if you haven't already. If you need more information about it, I encourage you to contact Pat. He can get you additional information, additional details, as we would say. But we need to know what you need that fits within those perimeters. How could this money best help you serve those with special needs that you are helping us serve? Let's begin this discussion. Rob, you want to call on our first speaker?
I'd be happy to.
That'd be great.
First of all, I want to thank our host here, Dawn Johnson. She rolled out the red carpet today, and we're happy to hear from her first. So,
thank you, Rob.
come on.
Hey, good afternoon, everyone. We're excited. I'm Dawn Johnson with the Florence County DSM Board. We're excited to be hosting this listening session for the commission. It's given us a great opportunity to share how we feel and what our thoughts are on the FMAP money that you guys have to help us boost and bolster the services for people with disabilities across the state. I just want to really talk about our board and sort of what we're going through. COVID was devastating for us, along with everybody across the state. Not just only ensuring that we were keeping people healthy and safe, but also our employees, working with them as we struggled through COVID and what was going on. We did lose staff. We lost some residents here at the board, which was also very devastating throughout the year. We feel like we're on the upside now. Hopefully things are getting better. We are reopening our doors for our day program, and thankfully people are coming, and we're helping them to continue to, being, as we all know, stuck at home, feel like you can't go anywhere. That happened a lot to people that we support, our residents, people that live at home. And what we've found is as they come back in, it's hard. I saw one guy pushing a walker, and I was like, what's going on? Oh my gosh, what's happened? And over time, being at home and not getting out. I think at times we take for granted those things that we miss, because even though it might be a small step, those small steps make a difference in people's lives every day. And for us, it was just like really telling, like, oh my gosh, just not being able to come, be with their friends and do things really impacted the people that we support. This is exciting that you have this opportunity to have these funds to help us continue to promote our services, but also to just make them better. That's all we want to do, is do what we can for the people that we support. One issue that we are having, which everyone is having across the state, not just in our service delivery system, but everywhere, your local restaurants and those kind of things, is finding staff. If we were looking at our numbers, we were doing our FTE report, and then we were like, oh wow, we have 60 vacant FTE positions. And as everyone has said, we've been doing driving around. We would take a day and stand at the road, and basically we're, waving people in to try to find good candidates to hire. And as others have said, we might start off with 8 people, but when we get down to it and we get to orientation, we can't. Some people don't even last a day in orientation. So we're losing more people every month than we're gaining. And so we're really struggling with that. So ways that we can compensate our employees, all of our employees, hiring bonuses, just any of those kind of things that we can do. I know it's a statewide crisis, but we are trying to take care of the most vulnerable citizens of our state, and we need to make sure that we find the right people, good people to support them. So that's one big key area. I mean, there is so much going on, and just looking at the rates overall, if there's any one-time things that can do, we, of course, shut down our day programs, the financial impact. We were able to, we didn't have to do a reduction in force or anything, but we were able to move people to other positions so we didn't lose employees. But, now we're trying to regain momentum, and just not being able to, with the transportation costs, everything's going up, food, just all of the expenses of our agency. So looking at just temporary rate changes to help us get through these harsh times. I mean, there's so many jobs out there, the competition to try to find the right people. It's just hard. I know that you guys are, this is difficult. You've got a really hard job to do, trying to figure out how to spend these funds. Another issue, and some of us, not everybody, has legacy properties, but we do. We have 4. I think probably being right here close to the regional center we have great buildings, but they do need work. I say they're great because they've served us well through the years. I have 2 ICFs, CTH2 home and also our case management building. So anything you could do to do some one-time things to boost, capital funds were great. We were on plan to replace one of these legacy properties, but then the capital funds sort of went away. So, because our houses are very old, just so you know. So those are one thing. Any kind of telehealth, I mean, I know you guys have heard, you're on board with that. That would be a great way to use the funds for us. But we appreciate all you guys are doing. We thank you for being here. And we really love people that we support, and we know you do too. And you're going to just make some great decisions for us and to help us just provide better services here in Florence County and across the state. So I just want to thank you guys.
Thank you, Dawn.
All right.
Don't sit down here.
Wait, we got questions. Don't leave us.
So fast.
Oh, okay.
What questions do you got?
Tell us your thoughts on how you would use telehealth. Expound a little bit more on and use it.
Well-
Telehealth. Tell us exactly.
I'm
Try to
going
be-
to put Elizabeth on the spot. She's the expert. She
Okay.
started a lot of that. She started that, for us.
Elizabeth.
Yeah, we're not actually participating in it at this point, but because there's a lot of startup calls and there's some other things. But I do know, and this is just in the general public everywhere, just trying to find a primary care physician is difficult.
It is very.
We're right here at McLeod and we've got MUSC and all that, but you can't get into a doctor. So especially with people that we support, just having the option, we've all gotten used to doing things over the computer and Zoom and this. So this is a great opportunity, especially for those small things. I know we're very cautious, and I know with them are too, everybody is, but just someone, if they are just not feeling well, something, we're going to get them to the doctor. We're going to see what we can do to make sure that there's nothing underlying, because you never know. Some of us might not do that for ourselves, because like we have a headache or we fall, we're like, oh, well, we're okay. But if somebody falls, hits their head, if they're having signs and symptoms or something, we're going to get people to the doctor. And we don't want to be in the emergency room for hours and on end. So that's what we would do, is use that service, especially for just small things, big things, because there's so many options with that. They can refer us to, hey, you need to go see this specialist or what. I believe Elizabeth's going to talk to them about that.
Go ahead, Jeff.
Yeah, look at that. Yeah.
I've got a couple questions for you too.
Okay.
Tell me about you said you have 4 legacy properties. One's the case management building,
What,
correct?
right.
All right, 2 ICF homes,
Right.
correct?
Yes.
And then 1,
Community training.
okay. Now, tell me what needs to be done in those facilities that could be funded.
Well, one of our homes is, several years ago, we got rid of our, I hate to say rid of, but our oldest home, which is over there on Palmetto Street.
Mm-hmm.
Now, that home was 50, 60, 70 years old.
Yeah.
So we have another property like that. That's a community training home that is in a historic district here in town. And there's not much you can do. It's a 4-bedroom home, but it's older. It needs to be replaced. There's all kinds of different locations. We need generators for our ICFs.
Okay.
We don't have any. We haven't been able to afford any. That would be one thing that we could, especially for those legacy properties. 2 of those legacy properties are ICFs. That would help us still to be in compliance with DHEC.
How many ICFs do you have?
We have 5 ICFs. So, those kind of things, it just needs maintenance. And especially now that sort of through COVID, everyone's been in the homes for a whole year and a half. And it's been,
Sure.
we couldn't just send people in to do big things like painting. We're always AC units. We're all feeling that this summer and stuff. So there's just things like that need
Maintenance.
Maintenance kind of.
Do y'all have a maintenance person, or
Yeah, we have
is it
maintenance
overwhelmed?
staff, and then we also contract stuff out
Okay, good.
to local people. Yes.
All right. What else you got? We might call you back up.
In
Okay.
the historical district,
Yeah.
can that building be renovated under historical?
You have to, there's certain things you have to do, like we had to put a roof on, and because it had 2 dormers, we had to go through the local city stuff, and we probably would have removed those dormers, just because of leakage and those kind of things, but we couldn't do that because of the location of the home. And it's just an old home that, like, the windows need to be replaced, those kind of things. It's helpful.
I think that would, because it's in a historical district,
Yeah.
I think that's something we need to look into. So, I'll help with that. Ms. Elizabeth, anything else you want to add? Subtract, multiply, divide?
Let's not fight for it, but.
Great segue, Commissioner Miller. We'll have Elizabeth Strauss and Georgetown Board come up.
Okay, thank you. I didn't know we were going to be on the hot seat.
Of course. We're on it all the time. Welcome to our world.
A little bit.
I'm the chair of the County Planning Commission, so I do know.
You know.
What it's like to turn projects down or whatever. Telehealth, first of all. We've been doing this, have employed a company for over a year, well, about a year now. And they are specializing in our population of people that we support. It's a very unique service. And the doctors that developed this model did it about 6 years ago, pre-COVID, with the idea that they were going to stop trying to treat people in the ER when they could avoid getting treated in the ER. So it's very simple. They said they were seeing a lot of people that we support in the ER for just absolutely not important reasons. So UTIs. And our utilization reports really bear that out, that most of the treatment they're giving us are non-emergent care. Now, when we need emergent care, they're sending us. And what is unique is kind of like what Dawn was talking about is if they say this person does need to go, but I'm going to call the ER doctor for you and tell them, hi, I'm Dr. So-and-so, and you're receiving my patient who has got this suspected condition. So when they get to the ER, they're whisked right in, seen right away, no waiting, and just totally treated differently. We tend to see people with disabilities treated a little bit less, nice is not the right word, but as a priority if they are there on their own. They're triaged differently, and that is borne out in studies all over the country that they're seen differently. So if you can avoid that or maltreatment or different treatment, that's a good thing. We've had some great outcomes. Stacy, I'm going to ask her to come talk about it, for she knows a little bit more about the telehealth calls themselves. If you want to come up and join me right now. Stacy is our day program director, but she's also done many things at our agency, and I want her to talk about the actual telehealth visit. Okay?
Good afternoon. Good afternoon. We've been, like Elizabeth said, using Station MD telehealth services for almost a year now. And I think the most beneficial of this program I've seen was during the pandemic, because it allowed us to keep people out of the hospital settings where the virus was rapidly spreading. So what typically occurs is we first got a grant to get the equipment that will be used to do the visits, such as the Bluetooth telescopes. We have a device where that's a Bluetooth where the doctor can tell the person's pulse. Oxygen level. Yeah, so we got the grant for the equipment initially. So if a staff had to make a call to the Station MD doctor, they would go onto the iPad. They only have the icons on the iPad that's needed. So they would click on the iPad, set up the appointment with the person who's responding to the call. Then the plus about Station MD is that they interface and communicate with their app, which is something we're already using. So the doctor will actually go onto their app once they've made the initial contact with the staff at the house, and basis on what they decide needs to occur, document that into their app. So it's really detailed information. The doctor will tell the staff, well, if, like Liz said, if they need to go to the hospital, they'll call ahead of time. If they need to just see a general doctor later, if they need a prescription, they take care of all of that for us. And again, it helped during this pandemic, and I am almost certain that's why we were able to keep our numbers so low, because we did not have to have people leaving the facilities if it wasn't necessary.
So you have this equipment in every facility
Every
you have.
location, yes.
Tell me what it costs to do Georgetown County. I mean, just
It
know
was
what the
about
cost-
$12,000 for all of
Okay.
our houses. Now, there are alternate ways. You don't have to do what we chose, but we chose to just have it everywhere. Because we didn't want people to have to leave to go pick up but we have a transportable bag that we had to evacuate for a hurricane. We just take it with us.
Okay.
But it does require Wi-Fi or a cellular signal or some connectivity, so that, the problem, that could be a problem, but they usually will deal with us if they know there's a connectivity problem.
Okay.
You use your iPhone. It's
All right.
as simple as that.
That's good. That's great information.
And you do not have a limit on how often you use the service.
Okay.
So you can, one month you can call 5 times, the next month you can call 15 times. They don't limit how often you can use the service, and they respond back within 15 minutes.
Okay.
With a doctor on call. And our nurses, they love it. And this also, again, during the pandemic, your nursing staff was stretched thin as it is. But if you had that support from that doctor with Station MD, your nurses can kind of rest themselves until they were absolutely necessarily needed, which they benefited from this as well as the staff. And it also encouraged the staff to make independent choices, to say, hey, I'm going to use my own decision and say, I'm going to call Station MD and let them tell me what needs to be done as far as care for this client.
Okay.
So it's awesome. We love the service.
I can say that we had one gentleman that had post-COVID, maybe 6 months out, he had problems that you noticed with some swelling. So we did a Station MD call, and they were like, ER visit right now, and he's got a blood clot. And we wouldn't have known that was a suspected thing.
That's right.
So it was a complication that we didn't know, and they were able to say, no, sorry, and he was seen immediately at ER.
Okay.
But seen immediately and getting immediate treatment. And other uncomplicated things like, I need you to assess this person fell out of the bed or tripped and fell. Can you please look closely at the skin? Can you please order an x-ray outpatient? And I don't have to go to the ER, and my staff don't have to go and be exposed, and yet they can go the next day and get it. Or he said, I'm going to send you an in-home x-ray. But they exist. They exist. They do exist. And they came right to the house and did an x-ray at the person's home. So it's been, and even lab testing, all in-house. So we've saved so much time in terms of staff time. But the other thing is the outcome. That's the most important thing. It's better treatment, quicker care, better assessment. And the notes are so detailed, it gives us a lot of, I'm not going to use the word coverage, but protection and training to the staff, because they'll say, here's what I've told your staff to do, and I'm documenting this in the notes, and we're going to follow up tomorrow. Next day, they call, and they say, how's the person doing? Are you seeing a better result? And it's just, it's better. You don't get 30 minutes of a visit with any doctor these days, but they're getting 20, 30 minutes one-on-one with the doctor and their staff person if they are having to answer it. So it's a quality. It's kind of hard, like I told Pat, I said, it's too good to be true when I first heard about it. And I was like, well, we'll get to investigate this. And sure enough, it's exactly what it is. And the training that their doctors get, the reporting from all the staff is that their reports are kind, compassionate, really want to understand what's going on with the person, look at their history. They go in therapy and look at their history, see what their diagnoses were. What primary doctor does that? I'm sorry. So,
It's really, of course, when you're introducing something new to staff, you get a little bit of hesitancy and pushback. But once they develop that comfort level that I have a doctor at my fingertips literally within 15 minutes to assess a situation and to support me, they love it.
Okay. Very good.
yes. So that's telehealth.
Okay.
On to my other points. Thank you very much, Stacey. I think Dawn hit on staff. The staff crisis that South Carolina has is no different than the entire country right now. So nationally, there's an entire direct care workforce crisis, which some of the HCBS money was really born out of this crisis that was going on as a result of COVID. But the fact that closed programs were closing, you couldn't find staff. And so I think that is a critical area that we have to talk about hiring. Preventing abuse and neglect. You're hiring new people. You can't train them well enough in the beginning because you're on your own. So I think that's something Jay's going to talk to you about. What are some ways that we could help prevent abuse and neglect in a better way than just doing an orientation training? the other thing I've heard about the HCBS money is serving waiting lists. Well, I am not opposed to that at all. So, but what I say to you is I don't think I can afford to open up any additional services at the current rate, to be honest. Nonetheless, if you decided that we're going to open up 2 CKH2s in Georgetown, you're going to get 2 4-bed homes. I couldn't find a house in our community. We have less than 1% of housing stock available. Plus, they're priced at $250,000 and up. And we don't have any housing trust fund money except $75,000. And you all don't give us any more grants for housing like you used to. So I can't afford to open up new houses unless you find a way to make that happen. In-home services, I don't know where they're going to find the direct support staff. So you've got to think about it. If you throw money at that situation, how are you going to solve the direct force work crisis, in my opinion? Day program, Stacy talked about that. We reopened this year, and we're still having some struggles with just being able to get a few staff. But in our community, it's not as difficult as in a larger metropolitan area. But we're almost up to 100%. We still have some holdouts who don't want to come back because of fear. And vaccinations, although our staff are probably 60% vaccinated, 60 or 70%, the individuals not quite so much. So our workforce education has got to improve a little bit in that area. I do think that there's some flexibilities that were in Appendix K that really should be continued and may have to be funded with the FMAP money. Like we have individuals who live in our residential care and they receive day services at home because they are 83 years old and they don't want to go to a day program anymore. So we'd like to be able to continue that, but if the Appendix K stops, that goes away. So I think that's a valuable, that if the person chooses they want to stay home and go do community stuff, we ought to be able to offer that to them. But staffing ratios have to be considered. And then we have 2 legacy properties. Ours are not as old as Dawn's. So, and we have generators. We paid for those with the FEMA grants we got several years ago. So thank you for that. I'm not sure if there's any more FEMA money, to be honest, but FEMA's a sore subject.
Y'all still have to evacuate, correct?
We usually do. We have our day program is for category 3, and it's in a non-flood zone. But when it's really bad, they will make us leave. So it's really up to the governor. Zone A, we're in B with that one.
I know yesterday we met obviously down in Charleston with the folks in Charleston, and they've got their building certified that they can stay. So they're asking for a generator to keep that facility open so they don't have to transport all those folks, inland. So I just wanted to make sure there wasn't anything like that available where you guys wouldn't have to move all your folks.
We already have a FEMA generator that was granted to us about 5 years ago.
Okay.
And it's been a godsend because we've only had to come here to our sister evacuation city, Florence, once in the last 3 years. And we've been able to stay, and that saves our staff time, costs. But we wouldn't stay if we were really risky. But usually we're okay.
Yeah. Well, it was an interesting conversation yesterday. They have a facility, it's a beautiful facility, and but they needed a $100,000 generator. And we asked, well, okay, they said, well, it costs us $300,000 to evacuate all these people. And we're like, how many times a year do you evacuate? And they said, on average, hurricane season, 2 times. And I mean, it just makes perfect sense. Why would we pay $600,000 to evacuate when we could spend $100,000 and keep them in place where they don't have to go through all that transition of being on a bus for 4 hours, etc. So that's why I'm asking these questions of you.
Yeah, I think we would all be in favor of avoid the cost of that.
The confusion of it. I mean, for our clients, we want them to be as comfortable, as possible. So that's why I'm asking that question.
Hard. Yeah, that is hard. And also then, these folks are put out and they're awfully nice to let us come, but it's not exactly comforting for them. So
Good.
How's your day program? How is it? Is the numbers up where you want them?
Not 100%, but probably 80%.
About that 80% of the 93 we have total. We probably have about 12 to 15 that are not back yet. So we kind of work to bring people in a little early. We did an A day and a B day, and we rotate. And we had folks who were able to transport. They transport, and then we use our vehicles and socially distance people. And And then once the AA and B day started working, we started incorporating more groups coming in on every other day. So we kind of try to look at different ways to bring people back until we got to where we're at today.
Okay, so my question is then, Ms. Johnson, you as well.
Yeah.
If you had, what's the name of the thing called more money? If you had more money, tell us how you would go about increasing the numbers in your day program.
Well, vehicles, for one thing.
Oh, yeah.
Because we have, I'm sorry, vehicles.
Yeah.
Vehicles are one thing because, you know, we are normally transporting, I don't know, 15 passenger vehicle where you have, let's say, 7 to 8 people. But due to distancing and you need staff to drive it, but due to distancing and all that, I mean, just having more transportation. I mean, we have a fleet of up to 100 vehicles, but you know, our county's fairly large, and especially our Florence area. I mean, we might have a route that we're going all the way to Timmonsville and back in here, and as Deputy, you know about that. So that's a good 45 minutes to an hour route to pick up.
Well, Johnsonville, I mean, Johnsonville's an hour.
Yeah, from Lake City.
They would come up there too, we kind of like.
Yeah, yeah, they're right there at the edge of that. So
Anyway,
in Williamsburg County, of course, we're right there. Because we're in Johnsonville, you guys are. So I mean, that's one huge thing. Now, personally, we're lucky in Florence County. I have 3 separate day programs. This is one building that we have. Other boards aren't that lucky. They have smaller facilities and would need to rent space, get additional space to serve more people, to social distance. There's all those kind of issues when you're looking, you know, just at what would you do? There's lots of options. There's lots of things you could do to help increase your services. And of course, I think it goes back to everything's going up. Gas, food, all those things, supplies. I mean, the supplies, the PPE, all those things that we purchasing or continue purchasing.
So am I hearing that there are constituencies out there that, if, for instance, in dealing with your transportation, if you had all of those things in place, how would it be difficult to increase those numbers? Or, in other words, are they out there?
Are the people out there willing to come back if we can go
Yes.
get them? Is I think what he's
I think it's like, I mean, we're in the same boat too, where, man, everybody's ready to come back. You know, they might not want to be on a vehicle with 7, 8 people, or the route might be too long. So there's everybody's at a different spot, and we're trying to help them feel as comfortable as possible and trying to be creative with the services that we're providing. So I can't say 100% everybody's like, yeah, we're coming right back, but I know those are just some obstacles that we have to face,
Okay.
especially the trip.
You just created a scenario. I am that person
All right.
that want to come to your day program,
Yes, sir.
but I don't want to ride the bus with that many people, but I want to be in your day program. Tell me how you handle it.
So if I get some money and I can get a different vehicle, I can look at what options they have, vehicles or ways that you can be transported, either paying some other provider to provide those services, or, you know, looking at the staff, looking at drivers, looking at the location where you are. That's key too, is where you're living, and trying to get you in. So I would try to figure out an option. But I know that, and I know what we're all thinking too, you know, the rates that we can pay for day program, you know, we don't, transportation and all, and it costs a lot, all the costs are there. But we're gonna get you there. If you really want to come, we're gonna get you.
I heard you mention the term rate. Tell us a little bit
tell us
about
what
you mean by
where
that.
your rates are and where they need to be.
Yeah.
Both of you, go ahead. I mean, we would love
Well,
to.
they're at 31.29, 28, 29,
Yeah.
right? Which was, you know, it's based on whatever the current pass-through rate is to DDSM.
Okay.
So that's really, the bottom line is that market study that I think Pat and them have asked Health and Human Services to look at the day program rates again. It wasn't part of the initial study, so it really needs to be studied, but rough, you know, we answered that we need a 1-to-3 ratio because you expect us to provide 3 people in a van as opposed to 10 to make a family comfortable. That's a lot of staff, and so that's going to drive your rate up more than triple what it is to include transportation.
I totally agree with Elizabeth.
Come on up, Stacy. That gets you on the record.
I totally agree, and it, while you asked that question, Don, I was thinking, if you said, hey, what can it take to bring the people back? The bottom line is going to be more staffing, okay? If we don't have the staff, we're not going to be able to socially distance people properly in order to bring them back. So if we can hire more staff, then we can reach that 15 people who say, you know what, my mom has an underlying health condition at home. She doesn't feel comfortable in here riding up under 5 or 6 different people on a vehicle. Because we have the vehicles, in our case, we have the vehicles, but it's the staffing that we're working around. And we're doing what we can with what we have, and it's working. But if we want to reach more, we got to get more. So I think that would cover a lot of our issues if we can take care of staffing.
Space-wise, y'all are okay in Georgetown? You know?
Yeah, we are. We're good. I mean,
We added on twice already since
Oh,
we've
yeah.
been in that building.
Okay, good. I mean, I just want to make sure you can social distance and that wasn't an issue for y'all.
Well, you know, and I think we have to look further down the road. Let's talk about the new rule, that some of y'all have heard a little bit about it. If we're supposed to be transitioning to providing more individualized day services, and the term workshops without walls many people have heard it, that a day program to some people is not a day program to somebody else. So how do you build flexibilities into your day program to allow for outside small group outings? The only way you can do it is to have a staffing pattern to support that for safety and security. So this kind of situation, yes, we need it for COVID to protect against the Delta variant that's probably coming, but we also need it to look at the future. How are we going to provide more individualized care? So that's my concern. And I think the other thing is, not only is direct support crisis a problem, we need to be thinking more about smart homes and more smart home technology. There are states that are using it to the nth degree, and they have houses that are totally staffed by remote, which is unbelievable. And it's not for people that have severe needs. But we need to be smart and thinking down the road about those things.
Okay, so staff, what is your current rate and where would you like to see it at that you could get folks in?
Well, if you look at direct support rates, it's 13 an hour for incoming.
Yeah.
Revenue, but, and our nursing LPNs are at 20. So
Say it again.
our nurses LPNs start at 20,
Uh-huh.
which, so if you were to up the rate for the direct support staff, then you gotta look at the LPNs too. So it's this trickle effect. So if I state that I would like the direct support staff to at least be making 15, I don't think that's a bad number. But there are others that are paying that.
So it's 15.
Locally, like the new,
I think different
Starbucks.
areas have different needs. I mean, I think obviously Charleston, and Columbia and Greenville it's going to be harder for them to get that staff than it is for us, and their cost of living would be different. And obviously Horry County and Georgetown is cost of living down there is obviously different than it is in Florence. So I think that's something that I'm very interested in as a commissioner, is the rate structure across the board, from top to bottom. And I will tell you, one of the things that I'm going to be looking at with hopefully a task force in the next month is looking at that issue as a whole and trying to make sure we're all within, some kind of reasonable structure. So,
and along with that comes the complications when you're trying to recruit people, let's say even for professional, but the school district has the problem, the hospital has the problem in our area. They cannot find a place for people to live. So it has to be a livable wage, and you've heard that term. I don't want to use it and beat it to death, but people have to be able to afford where they're going to work. So we're facing that problem in our county because it's a very rural but beachy, gated community. It's quickly becoming like Beaufort and Hilton Head. So that's a real problem for us. We're seeing that. So
we're gonna. I think the wage for the staff, we have to make it to where it's going to be competitive for them to want to come work for us. Because at the end of the day, when we look at the responsibilities that they have as a direct support professional, you have people's lives in your hands on an 8-hour shift or a 10-hour shift. So whatever the wage is, it has to be something that's going to be competitive for them to stay, because they can go down the road to Polly's or Merle Dillon or Myrtle Beach and make $15 an hour in a fast food restaurant, and all they have to do is do their job and go home.
Right.
Versus the responsibility they have in the houses. So if we have something that's competitive, I think that would assist us a lot in multiple areas of the needs. Like Liz was saying, as we move forward with this final rule setting, we're going to have to do more individualized tasks versus group tasks. And the only way we can do that is if we have adequate staffing to be able to properly group people.
Okay. Good.
Any more questions for me?
That number 15 and 16, that's,
Is that coming out elsewhere? Or are we shooting too low?
no, I'm asking a question. I thought I heard somebody say 15 on that side.
Yeah, that's
Yeah.
Georgetown.
Oh,
Yeah.
okay.
But you know, that's true. I think that, the other thing is, if you want to recruit college educated folks, you're gonna, you know, I don't know. Jay might have something to say about what it looks like, because he works at all different, counties, he can tell you. So, anyway, any more questions? We'll sit down, you can ask. them
Thank
later.
you. Well,
Thank
you know that you can always call us. We'd love to communicate.
Okay. I want to point out, now he doesn't want to speak, but I point out that we have another executive director here, Carrie Rogers from Jessica Services. So if you have any questions, Larry. You may be able to get him up here.
He's welcome to come talk to us. Blake. What?
Okay, and like the way
Okay.
from Marion Dillon. It's also here.
Wonderful.
Oh,
They're
okay.
sneaking in on me.
Glad to have you.
I'm listening to one little thing.
Come on. Come on up.
I do want to say thank you for, I'm Terry Rogers, Chesco Services. We operate in 5 counties, mainly Chesterfield, but we also serve a little bit of Lancaster, Marlboro, a little touch of it. We serve YP programs in Kershaw County and Richland County. So we've expanded those areas. Chesco stands for Chesterfield County. We don't like to say that too much, but anyway, but that is where the name came from. But we do appreciate all you've done. I've listened to the other sessions. That's why I didn't contribute. They've all covered. They did a great job in covering the issues. I see no reason to bring them back up. Staffing is the challenge. That's the huge challenge. I need 100 people right now. I'm desperate, and I serve the high management units in the state, so that's pretty challenging, especially at these rates. So we have some very serious situations where staff are doubling up. I've been in the units working. During COVID, we got so short that I had to cover shifts myself. That's pretty hard when you're in 50 locations. So we've had some very difficult challenges in the last year and a half or so, but we're getting there slowly and appreciate what you're doing. And I look forward to doing whatever we can to make services better.
Thank you.
So what is it, the one thing that you haven't mentioned yet
That's all I'm gonna get up here.
that will make your life better? What is that?
One thing would be to raise the rates of the salaries we can pay our people. But as another provider had told y'all previously, that creates a lot of issues such as compression. I mean, I've got direct care making almost, or actually overtime, they're making more than their supervisors who are working 7 days a week on call. So we've got some serious compression issues because of the $3 raise we've given our direct care without giving it to other workers. So everything creates a domino effect. But that is the biggest issue. As one provider told you, I think it was in the Charleston area, we have restaurants paying $15 an hour. So I do operate in 5 counties. So in the urban area, the challenges are different than they are in the rural areas. Distance is a big issue in the rural areas. So every area is different. Therefore, I know your job is going to be very challenging given the variety you have here of providers. Some providers only do case management. So you've got the most diverse provider group we've ever had since I've been doing this service, which has been a long time. And I can tell that. Anyway, but that being said, it is, I think the biggest challenge to answer your question is the salaries and getting the workers.
How's your daycare going?
Daycare is improving. I'm different from a lot of people. I have 240 beds. So therefore, the biggest portion of my day program is my residential. But I do have some others in the community. We're probably about 50% thereabouts at that. We're trying to encourage them to get the vaccines before coming in because of the issues they're describing. I can serve them in my workshop if I get more staff hired. But my challenge is getting them to the workshop safely. And that would require double routing, or more vehicles, or whatever.
Thank you.
Welcome to Dizzle Gillespie country.
That's my neighborhood.
That's it.
Okay, next we're going to hear from Mr. Jacob.
He played pro ball.
I wish. My name's Jay Cole. I'm a board certified behavior analyst and a BDSM approved provider for behavior sports. So I'm coming at it from a little bit different perspective. You know, if you'd have told me 2 years ago that we were going to go through a pandemic and you take people with disabilities and lock them into houses for a year straight, I would say impossible. Being a behavior analyst, and the behaviors will be too explosive. You'll have staff injuries. They'll be tearing the houses up. And I commend the staff that I work with, and I try to reinforce them. I don't have money, but I socially praise them and tell them how much I appreciate the work that they do. I work with Georgetown. I live in Pawleys Island. I work with the Georgetown board and the Marion board. Both of my bosses are here. So, but from a behavior support perspective, you certainly need the people, like what the directors have talked about. But those people need to be trained. They need to be trained in good behavior management strategies. And we have these BSPs, and there are specific interventions for folks. But what I've seen is staff need more training than that. They need more competency-based behavior management training. And to speak to that, I convinced Elizabeth a few years ago to host a 2-day behavior tools class, of which we've trained in school districts and trained down in Florida, a bunch of foster families, just better salt-of-the-earth behavior management strategies. 2-day class, we teach about relationships. We teach about not using coercives to manage behavior. We teach about how to actually implement positive reinforcement strategies in a moment-to-moment sort of way. See, the staff, moment-to-moment wise, they got to know, do I ignore this? Do I attend to that? Do I reinforce that? It's a moment-to-moment constant behavioral curveballs getting thrown at you. If they don't have really good, solid training, that's where you get your abuse and neglect. If they don't know what else to do, a human being will fall back to coercive measures to manage behavior. They will. That's where the training comes in. You certainly got to have the people, but you got to have the training too. So what we saw from that class was, and Stacy can testify, she was in that class, is we saw staff come out more confident, more assured that they can prevent problem behaviors and manage problem behaviors. So we saw some positive effects. I even talked to Taisha, one of our staff over there. She said it completely changed. She'd been in it. She'd been in our business for a few years. I don't know how long Taisha had been before she took behavior tools. But she told me last week, she goes, Jay, that class completely changed the way I look at behaviors and people with disabilities, how to treat them, how to see staff. If they're just thrown into the job, they almost look at themselves as a cop for people with disabilities. No, you can't do this. Stop doing that. Don't. What that does is create tension and problem behavior. But they don't understand how to teach a skill, break a skill down, reinforce. All the things that we know in behavior management works with people with disabilities. And, you know, the staff that went through behavior tools down in Georgetown are some of our best staff now. They have the best relationships. They're just really good staff. And so that was one thing I wanted to talk about. If we had any time we had extra money, invest investing in behavioral training for staff is a great investment.
Okay, quickly. First, how much would that cost us to do per person? Say, for example, if we wanted to do it for individuals in our DSP programs and in our house residential programs, I need to know what it costs to put them through it.
Yeah, well, we've trained this in various entities, school districts and Elizabeth's EDSM board, but generally $150 to $200 a participant.
Okay.
And we usually put 15 to 20. The reason we keep class size small is it's competency based. In other words, I teach the skill and then I watch you demonstrate the skill and I give you feedback. Dr. Denny Reed has done a lot of research in this area. That's the best way to train direct support staff, not by talking to them, by actually having them do the skill in front of you and giving them feedback. Dr. Reed talks about that. But yeah, $150 to $200 per participant. Usually class size is 15 to 20. I think that's what we taught in Georgetown. And we've got a church to volunteer the space. It was just a good training and got a lot from that.
Quick question.
Yeah.
How do you feel about your model?
About
Your model,
my model?
your model, training model.
Your
that
training
you're talking about now. How do you feel about it?
I tried to do the training model, like the demonstration that I
Yeah.
just talked
Yes.
about.
Yes.
Absolutely, it's effective. I've seen staff still, after all these years, they're still using the skills even after a 2-day training. Now, granted, I'm there every week coaching and monitoring and helping as a good behavior support provider, I believe should do. I try to monitor my BSPs at least once a week. But at least that gave them the foundation, and then the BSPs are sort of on top of that. I kind of tweak the BSPs based on some of the stuff they learned. The problem is they don't have the foundation. You're throwing staff in with very difficult people with disabilities, and they don't have any behavioral training or foundation.
So basically, your model and you, the great Mickey Mantle back there, his technology, are you saying then that we could create and have a training model that you could help to implement around the state?
We could do like Dr. Reed talks about, a trainer of trainer, where you got multiple trainers around the state and you could train different entities like that. Yeah.
And you are that man.
I can't take credit for the curriculum.
Sign the paper. Sign this one. I'll fill it out later.
Now tell me, are you a DDSN employee? I'm just curious. No.
I'm actually what's considered DDSN approved behavior support providers.
Okay.
So these boards.
So you own your own company?
Yeah.
Okay.
Yeah. I've got, I think, I don't know, I've got 20 cases, I think, in Marion. I've got about 10 or so in Georgetown. And I contract with their agencies to provide behavior support.
And what is the name of your company?
Applied Behavioral Services.
Okay.
That's an easy question.
Yeah, I got it. And you're out of where?
Always out.
Okay.
He works all over the state.
I have. I mean, I've been
He's
providing.
gonna be working in a lot of other places.
As you can see from my gray hair too, I've been providing behavior support for a while, and I've provided services in Charleston and Berkeley counties, or 2 counties that I used to provide. But I also contract with public school systems. We do ABA therapy for young kids with autism. I got a variety of different hats that I wear.
Okay.
But this is something that I'm invested in. I went to school. I got my degree in developmental disabilities and behavioral psychology. And it's an area that I always wanted to, I was passionate about, and adults primarily. And so anyway, but the curriculum that you're talking about is actually born out of Florida. Several years ago, they had a problem with foster families and abuse and neglect and so forth in foster families. And the state of Florida asked their universities to get together and create a behavioral curriculum to teach foster families better behavior management skills. That's where this curriculum came from. And it's very jargon-free, it's user-friendly, no big terminology there. And the feedback we got from the staff was pretty cool. They enjoyed it. They are using using the skills.
Okay.
And it just, if you got BSPs going on, it complements your BSPs. You know, it works with your BSPs, but
And it helps resolve a lot of the issues that are occurring at a lot of these. That's what I'm hearing.
that's exactly what I'm saying too, is, and by the way, I appreciate you guys coming out and listening, and shows you really want to try to make positive changes in the system.
We do.
But yes, if people aren't trained and there is behavioral issues going on in that home, watch out.
Yep. I want you to take one of my cards, and I'd like to have one of yours if you have one.
Okay.
You good?
Very good. And the one last thing that it's kind of come up, I don't know if y'all heard this in your meetings and so forth, but we have situations in Georgetown and Marion County where you've got an aging parent trying to take care of a person with disabilities, and the person with disabilities is giving them a fit. Okay, their problem behaviors left, right, all this kind of craziness going on in the home. They request a behavior analyst to come in and help and work with the consumer and their parent. There's a problem with that, and this might not be a DDSM problem. They make us bill Medicaid directly, you know, with the CPT codes and this and that online, and you might get paid 3 or 6 months down the line. There's a problem with that. That's why we as behavior providers are not doing that work. I don't know if y'all know about that or not.
They don't accept those referrals anymore.
Nobody's accepting them because you can't get paid.
That's what I, pardon me
Is that
for
what y'all get up here?
interjecting, is when we unbundle it.
Come up.
Yeah, because I'm hearing a hitch in the system now.
Yeah.
Well, that's definitely a hitch.
No,
But it's it's people that live at home. That's the
Yeah.
distinction. Because if he's working in our residential, we get paid and then we pay him. And we control his schedule and we work everything through him. He comes in and trains and he bills us for his time. But in this case, it's not that way. The authorizations work differently. You don't know whether you get paid. And anyway, but also I was going to say that when you unbundle the residential rates, I'm fearful that you're going to you'll take that out and make them bill Medicaid. I hope not, because I want to continue to get the service we get now. And the families that are at home getting on the critical list, we could avoid it maybe if we had a mechanism to ensure that somehow they got paid in a different manner. I don't know. So, yeah, it's a
Yeah, I
problem.
think we can help some of these families. It's just if you got, like recently here in Georgetown, I had a choice to make between somebody, a 19-year-old kiddo with autism that was really giving his mom hell on wheels, and a residential case that they just got. Well, I'm going to take the residential case because I can get paid from that in like 2 weeks, where I don't have to. I'm a clinician. I like working with people, training. I don't like sitting in front of the computers with CPT codes trying to bill Medicaid directly. That's not my skill set. And I'm kind of a one-man show. So I think that's why there's not as many behavior support providers working in those homes with those families.
when you said something that's key, training the trainers.
Yep.
That's how we can really,
That's how you spread it.
yes.
You train competent people to go out and train other people.
I knew there's something special about you.
Well, we are recruiting, aren't we? We're up here, would you like to come take our job?
Real nice shirt.
Look at the hood. She's like, Chloe has a tendency to take us good ones, you know?
We gotta hear,
Can't give us
We have to hear
Wesley to
from
come out.
we have to hear. Come on now.
Come on, let's hear about your
We
program.
gotta hear about Dillon, South Carolina.
No, Marion or Dillon?
Marion.
And
Dillon. Okay, that's
There I
right.
am, Bill.
Old man Schaefer country.
Good evening. I'm the newbie in the room. I'm the interim executive director for Marion Dillon. Pretty much I'm in agreement with everything that everyone else has said. Not on a bigger scale, but we're having staff shortages as well. Transportation. I mean, we have enough vans. Marion a little bit better, our Dillon Center having to do double routes, you know, in order to socially distance. But here comes the issue, even if we had more vans, we need staff. There were a couple of times we reopened in October where you have one or two people call in. We were fearful that we might have to close. So that's always an issue. You know, of course, it's nice to have an increased rate for the direct support, just like I think, you know, everyone has said, but what creates a problem is I'm all for raising the rates for direct care, but then you have to start thinking about my case managers and my EIs. If we get the rate up to $15, they're going to be right behind, you know, the EI and case managers. They're only getting like 18 and some change. So it's like a domino effect. So I'm all for raises, but across the board would be for Marion Dillon. As far as we have some building and maintenance issues that, you know, we could benefit from if we had the extra money. I'm primarily, you know, from the case management aspect, but since I've been doing the interim, I've been kind of going into more of the facilities, looking at some things. I mean, you know, we have older homes as well that need repairs. Of course, you know, moving forward with the final rule, you know, we were told, you know, we can't really expand on, I guess, Dillon's, you know, like the centers, because we're supposed to be kind of serving people without walls. But like our Dillon Center is an older building, it's very chopped up building, 3 separate classrooms. So that has been a challenge for us to serve people and socially distance. Our Marion Center is a newer building, you know, more of an open flow, so we don't have that much of a problem. But if we had money and if it were possible, you know, we're just kind of, the Dillon Center, we did an expansion a couple of years ago, and, you know, it's still overflowing. So if we have another type pandemic of any type, just throw social distancing out of the woods. In terms of our attendance, we're probably like 60%, give or take. A good bit of our consumers have had the vaccine. It's kind of different, you know, because I've worked 2 different counties. Marion County, for some reason, most of the employees have received the vaccine. Our Dillon Center, not so. And we offered it, you know, we had CDS to come to the job site to provide it. All they had to do was just drive up and take it, so, you know, so. But like I said, overall, pretty much the similar issues that everyone else is having, recruiting staff. But then again, staff retention and then staff training. I think we bring people in, we take them through the orientation, but I don't know if they truly understand the behavior that they're getting involved with. So I think that would be an advantage as well. You know, more intensive training would be beneficial. But like I said, I think all of us in the PD region pretty much share the same problems, just maybe out of a bigger level. You know, obviously, in Florence County, and, you know, they're much bigger. So, but that's all.
Thank you so much.
Before you leave,
She's gonna ask a question.
I know, that's why I didn't want to
I'm not gonna ask you, I'm gonna throw out a scenario and ask your thoughts. Suppose FMAP monies was put into a pot at each of your location and central office for grant writing, finding, because there's a lot of grants out here that a lot of it requires matching, am I correct? Matching funds that would be at your disposal, same as consultants, outside consultants that you need to, let's say you needed to do a special training component and you didn't have to go into your coffer. How do you all feel about that? Everybody don't have to speak at one time.
But everybody
doing a
does
lot
have
of
to
grant
come up.
writing. Okay, come up there.
Yeah, you have
You want to answer? Go ahead. No, I'm the new kid.
I guess I want to make sure I understand what you're suggesting.
No, you don't have to.
put all the money in that, but let's say we put a percentage of the money.
Right.
Within each district, within each county, and we put a percentage of it at the headquarters and said, okay, we're here to match. Go see what you can get in grants and we'll match it.
Well, the problem we experience in Georgetown, the two foundations that we deal primarily with, Lackawanna Community Foundation, Charleston, and the Bunnell Foundation, we get loads of grants for them, for kids,
Okay,
not for adults,
okay.
and not for people.
Is that our primary business is staff driven. I mean, 80%, 90% of our costs are staff. Am I right? Is that yours?
Yeah.
And no grant agency will pay for operating costs.
Yeah.
They just won't do it. So if we need a consultant, that might be a different thing for a specific purpose.
I say
I got
specific
you.
first.
Gotcha. I understand what you're saying.
Anybody else want to add to that? I haven't heard from these two fine ladies right here.
Michelle's her back.
Just to be.
Terry has a lot of money.
A lot of consultants in Jesco. We always have. It's always been something we've always used. Grant writing. Now, we probably have to go out and consult with somebody to do grant writing because they said done DD council grants and all that in the past. The problem is, I think Liz just said, it's for a one-time deal and they expect you to continue it, and find the matching money as it goes on gets very difficult. And to be honest with you, I quit applying for those for that very reason. Even though there were some very good grants, I had some very good success, but you have to analyze, is it worth the labor up front for a short-term grant? And we determined that we were better off to focus on more longer-term projects.
Okay, but the consultant part of,
I use consultants, Jay's talking about, for behavioral services. I use them for QA services. I use them for nursing oversight. I use them for a little bit of everything. I've always wanted that outside expertise. Also, I serve on the Anchor, which is the National Trade Association for what we do. And I was talking earlier about the day rates. We have some of the lowest day rates in the entire nation. That is factual, based on facts.
One can I ask a question?
About grants, how would that, I guess I'm going to ask you, Pat, if you did grants and we then procured another amount of money, that doesn't help your cost reporting, does it? Because you're only going to be able to write off the cost for the grant gigs, not the stuff we matched, right?
I think it depends on how the money's used. Shows how they use purpose.
We might be able to. I just wondered if Because I always kind of knew that excess money isn't always seen as a positive in the business. Yeah.
Yes, I see what you're saying. I think it'd be accountable.
Yeah.
We may not get it matched.
Do we have questions online?
No questions online from the chat.
Anyone that has any questions, please let us know.
Yeah, please let us know.
You guys did great.
How many did we end up having on chat?
About 25.
About 25. So that's great. That's great.
We have one comment.
Okay.
South Carolina pays the least amount to caregivers that care for individuals with the highest and most complex needs.
Okay. All right, and if you want to keep sending in questions on the chat, I will turn it back over to the commissioners and let them ask any further questions they may have and sum it up.
Commissioner, do you have any questions?
It's just good to be here and to see the faces. And just know that this commission and this staff, statewide, we got real good here. Because you guys and those constituencies that you represent, they are the feet on the ground. That last person that's waving at you can give us some information that can help move this ship a little easier. So we are wide open on this side. You all bring it, and we'll check with the babe. See what he says. Thank you, and I enjoy it.
Ms. Bowley, anything?
Well, thank you for having us. It was a really great group of speakers.
Great. I just want to thank you all for hosting us, Dawn, and I want to thank all of my EDs for being here today. And I love meeting both of you. I think you're going to be true assets to us as commissioners to be able to gather information from you and use your services, obviously. Notice I added that in there. I'm still recruiting. So I just want you to know that while we're not here every week or every month, we are available to you all the time. If you don't have my new card with my new phone number on it and my new email address, DDSN has given us all email addresses and telephones so that you can reach us at any time and keep them with us all the time. We want to be accessible to you. We want to listen to you. We want to take your ideas and be able to serve our community and to serve our constituents. I've sat in the seats you're sitting in. As parents, those in online, as parents, I've sat in that seat. I know what it feels like. As a board member, I've sat in that seat and I know what it feels like. And we feel your struggles and we want to help you all we can. If you still have comments or questions, call me. My email is stephanierawlinson@ddsn.sc.gov. Those comments to me online, you can call me on my cell phone to you. And again, I just want to thank you for your time and thank you for being here and thank you for providing us this great information. I filled up the back of every empty page I had from you all. So that's Charleston. So hopefully we will come up with a plan and be able to give y'all some information in the next 30 to 45 days.
Easily.
Yeah. We hope that y'all will have some answers soon as to what our plan is. Okay. Thank you again.
Great.
Okay. We want to go ahead and end this, but we want to once again thank our host, Florence County Board of Disabilities, and Dawn Johnson. Thank you very much for having us here. It's been a great discussion. Again, all of these sessions are cataloged on our website page. So if you've missed any of our listening sessions, you've heard commissioners refer back to listening sessions in the past. If you want to go back and see what was discussed, you can do that on our webpage as well. And go ahead and send us any comments that you have that you think of later on. But we will go ahead and end that for today, and we will sign off right now. Thank you all very much.